Hey, it's Dr. Centeno. Thanks so much for joining me this Sunday morning. Got an interesting topic this morning. We'll talk a little bit about just some 2026 ePICL updates, and then you can ask questions about that topic or really any question at all. As I always say, try to get your questions in early, and to ask a question, you comment wherever you are. So if you're on Facebook, just put your question in the comments on Facebook. If you're on YouTube, then just put your questions in the comments on YouTube. And then I'll see that here, and hopefully I'll get to that question. That's one of the reason I asked you to try to get it in early, because at the end of the day, many times there are a dozen or more questions I never get to that come in later or during this broadcast. So again, as usual, we'll start with maybe a 10-minute didactic talk, and today's is about what's involved in the 2026 version of the ePICL procedure, what's changed, what's the same, and then we'll get into Q&A. With Q&A, you can ask a question about this topic or really any topic at all. Focus here is really questions, is answering your questions. I often find that patients learn more from other patients' questions than they do with regard to me just out there lecturing at them. So that's why I try to do it this way, do 10 minutes, talk about something, and then about 50 minutes of just question after question after question. Again, if you're just joining us, the best way to get your questions in is to put them in the comments, whether you're on Facebook or on YouTube. I'll see those questions here. Again, if you get your questions in early, they're much more likely to get answered. Usually there's a dozen or more questions by the end of this that I just can't get to in the hour I've got allotted for it. So we'll get started here. Going to be talking about what's involved in the 2026 edition of the ePICL procedure and what's new. Again, you can ask questions about that or really anything as the time goes on. So let's get into that ePICL procedure and what's going on with that. So what is the ePICL procedure? It's to say it in fancy medical speak, the percutaneous, intraoral, meaning from the front here, injection of bone marrow concentrate and platelets into the internal craniocervical junction ligaments. That's going to be alar, accessory, transverse, AAOM, and other ligaments that you can reach from the front using endoscopy, a 3D printed 5.5 now gen mouthpiece, dual access serum fluoroscopy, contrast confirmation, and digital subtraction angiography. So quite a mouthful there of medical terms, but basically it's a highly precise injection of the ligaments that hold the head on. And these ligaments can only really be reached from the front. You can get different ligaments from the back, but you can't get these internal ligaments from the back. So the procedure evolution here, really, this goes way back. I first started thinking about this procedure, doing it in 2013. And that's primarily because I had a lot of patients who clearly had upper cervical problems, but they also had instability, and they just weren't responding to posterior injections. So by 2015, I did the first couple of cases. By 2017, we started to realize that we needed a 3D printed mouthpiece to make this work, because we really couldn't find anything off the shelf that you could x-ray through and would accomplish the job of keeping the area open while you had the tongue depressed. And so by 2018, we initially started prior below atlas. Then we started adding it above atlas, made some changes to the mouthpiece. By 2019, just further dialing in that injection above the atlas. By 2020, There were more mouthpiece design changes because one of the more challenging things, especially if a patient is overweight, is that their tongue ends up picking up and their whole intraoral cavity where you breathe through ends up picking up weight as well. So it becomes more difficult to keep their tongue out of the way and to keep the area open. And by 2022, it became really critical that we add a second C-arm. And that's because with a single C-arm, the procedure was just less accurate. And if we were ever going to get to more accurate targeting of these ligaments, you needed to have simultaneous from the front and from the side views so that you could see exactly where that needle was at all times. Outside of that, you're constantly moving from AP to lateral, AP to lateral, AP to lateral, and it's just not as accurate. Then by April of 2024, I added in what I called the ePICL variant, and that was really rethinking the entire procedure and how the procedure was done, simply because there were times where we were struggling to get into the dense alar bands, and alar was one of those ligaments we really wanted to try to target. So that required a completely new procedural approach, a rethinking of how this thing was done from the ground up. And then through 2025, really gaining a lot of procedural experience because cases started to really explode in 2024 through 2025. Went to that 5th gen mouthpiece, which was a real game changer. It really allowed us to help patients and control their airway when we had those edge cases where we had patients whose airway was difficult to control. It now became much easier to control. And then this last couple of months, I've really been dialing in accessory ligament flow, understanding how to ensure that we're getting that, and then transferring that knowledge over to Dr. Schultz, Dr. Pitts, and Dr. Merkel, and then have worked on some continued perfection of transverse ligament flow. So while I'd love to say that the procedure is 100% done, it may never be 100% done because I love improving things as we go, but it's getting there. But I can say the procedures that are being done currently are better than the ones that were done last year, which are better than the ones that were done the year before that, and on and on and on. So again, that PICL to ePICL evolution, with the PICL, it was difficult to get into that dense alar band, just rework the whole thing, and now it's really quite different. The PICL versus the ePICL and what we can do now with the ePICL is really night and day. So very glad I made those changes to completely change how we did this thing. Some of the more recent additions is that we've added the suboccipital nerve hydrodissection, and that's because that's the nerve that goes to the rectus capitis posterior minor, which can be very important in patients that have any kind of Chiari 0, Chiari 1. And we added in more routine vagus nerve hydrodissection and dialed that in. So those are the two big additional components. Now, the procedure itself includes a lot of stuff, right? There's the anterior injections, there's the posterior ligament injections, there's the 0 to 3 facet injections. There are all these different nerves that we're treating: greater occipital nerve, lesser occipital nerve, suboccipital nerve, superficial cervical plexus, vagus nerve. All of that is really part of a standard ePICL, but all of that also gets customized to each patient. Procedure data collection, we have a registry tracking outcomes using standardized questionnaires at 1, 3, 6, and 12 months and annually. We also have an As Seen case series in the office where improvements are captured in between procedures. That's both free form, i.e. I can now do X where I couldn't do X before, And we also take a SANE score, single assessment numeric outcome, or numeric evaluation at that time. We also now have low-dose DMX on site, and that's up and working. That started kind of in January-ish, and that's continued to improve. So now that's fully up and running. I've also produced sort of a different type of DMX, right? One of the concerns I had with DMX before is I was getting a lot of views that I wasn't using at all and that weren't important, and yet patients were still being exposed to x-rays to get those views. And the other was that the reports were just not up to snuff. They weren't really patient-friendly enough, so a patient could instantly understand where they were in all of this. Some of the reports were just way, way, way too complex, and some of the reports were way, way too sensational. So put together a completely different reporting format. This is a difficult procedure to do because it involves controlling a lot of variables that, as an interventional spine provider, you're usually not controlling. One is endoscopy, meaning you have to be able to see the area at the back of the throat that you're injecting. You've got to be able to maintain a sterile field there. If your field becomes unsterile, you've got to be able to see it. So for example, we had a patient 3 or 4 months ago, for whatever reason, had a massive amount of fluid that she was bringing up from her stomach during the procedure. And we knew, because we had visualization of that area, that we needed to end the procedure because it was impossible to keep this area sterile. You need a 3D printed mouthpiece. There is no mouthpiece you can buy on the market today that'll work for this area and for this purpose. So we had to make one. And then there's making one, but then there's dialing it in as time goes on. So there's a Gen 1, a Gen 2, a 3, 4, 5, 5.5. And that comes only from procedural experience. What's working on the mouthpiece? What's not working on the mouthpiece? Which patients can you treat with the mouthpiece? Which patients are falling through the cracks on the mouthpiece, i.e. the edge cases? You have to have dual axis fluoroscopy to do this right. That means 2 fluoroscopes working at the same time, one going this way, one going that way. And then you got to have extensive training, and we'll get into that extensive training piece a little bit here. Number one is you have to have high upper cervical facet injection experience, and that's super duper rare, right? If I take the United States, which has by far the world's most sophisticated medical care system, one of the downsides of the United States system is that it's ridiculously expensive. But one of the upsides is there really is no equal, meaning at the end of the day, worldwide, there isn't another place on earth where you have access to as much medical care and different types of medical care as the US. So even in that system, the number of physicians that I can count on who have extensive experience with 0-1, for example, that's the facet joint at the very top, I can count on 2 hands. That's it in the United States. Meaning that, and you've got to have that before you can do this type of procedure. This isn't a weekend course, or what we call in the see one, do one, teach one procedure, because training takes months of dialing in those injection targets and making sure you're doing it in a way that's safe for the patient. So who's been trained so far? Dr. Schultz, Dr. Pitts, Dr. Merkel. That's it. That's all we've trained worldwide. Those are all CSC Colorado providers. And again, nobody outside of those physicians in Colorado has been trained to perform this procedure. You might hear otherwise out there, but if you hear otherwise, that's fiction. And one of the hardest part of an ePICL procedure, or even a 0-1 injection procedure, is dealing with those edge cases. So a good edge case problem is full self-driving, right? Tesla had this experience more recently, where they had 6 billion driverless miles, and their FSD would still do weird things in edge cases. What are the edge cases? Well, it comes across something it doesn't see a lot. But the problem with driving is there's tons of those, right? You drive for an hour trip from town A to town B through town C, and you're going to see 5 or 10 different edge cases that are not all that common. Now, when they got to 10 billion miles, all of a sudden things changed. I have a Tesla. I would say that if the navigation were better, sometimes it chooses bizarre navigational routes, I would use the full self-driving about 80, 90% of the time because it's a better driver than I am. But that was the difference between 6 billion miles and 10 billion miles. And ePICL and these hypercervical injections are the same way. You're going to run into a lot of edge cases that you don't see every day. You're going to see contrast flows that don't look like the ones you're used to in a certain area. You're going to see weird anatomy that someone has. You're going to see problems with positioning a certain patient, and how do you work around that? You're going to see issues with anesthesia and other challenges that when they add up to 3 or 4 different edge cases in the same patient, the risk goes up unless you know and you've been trained in how to deal with that edge case. So if you've done thousands of these like I have, or you've got access to someone like me who has done thousands of these, like Dr. Schultz, Dr. Pitts, and Dr. Merkel have, you can learn how to get around these edge cases, but they're frequent in this procedure. And again, just want to, I've talked about this more times than I can count, but what I call fake and bake intraoral procedures. There are practitioners out there claiming that somehow they were trained to do this. They have not. So there's inadequate training there. There's inadequate imaging being used. And in my opinion, again, if you're using platelet-rich plasma from a blood peripheral vein source, you're increasing the risk with this procedure primarily because that's the weakest link. The weakest link of the whole procedure is a medical assistant taking blood from a vein. That's the highest risk part. Now, there are other high risk parts, right? Not knowing where to put the injection, how to deal with edge cases, etc. But when it comes to the difference between doing a bone marrow aspirate under a surgical prep versus a take blood from my vein type thing, that's going to be a high risk step because you've got to rely on a lesser trained practitioner to do that right if you're making PRP. So in summary, the ePICL is, I've said before, 90%, 95% dialed in, but continues to advance. And that's because as I do more of these, and I'm probably getting close to 2,000 procedures, something like that, I can start to see that there are little ways and tweaks where I can make it better. I also come up against more of those crazy edge cases where I can give that information to Dr. Schultz, Dr. Pitts, and Dr. Merkel. And again, the problem here is that there are no texts that you can go to look up how to do this injection. There are no papers available. So only significant reps, meaning doing the procedure a lot, produces more advances. And again, only CSC doctors have been trained at this point. So let me stop that sharing and we will get into some Q&A here. Let me change this. Okay, Q&A. What determines whether to treat muscles? I'm going to have to move myself to the middle of the screen here, just so we can make sure if you're viewing this on a vertical screen, you can see it. So what determines whether to treat muscles and nerves at the same time as the ePICL? And should you continue to treat muscles and nerves between first and second ePICL? Muscles and nerves. probably the easier one to answer is certainly going to be nerves, right? Nerves are a critical part of an ePICL procedure. Why? They're a critical part of that procedure primarily because they get beat up with the instability. And then once they get beat up past a certain point, they start taking on a life of their own. And so now you've got two problems to treat. You've got to treat the instability and you've got to treat the nerve. On the muscle side, we do treat some muscles, more muscle tendons, with things like PRP or bone marrow concentrate. But really, if you're going to be treating muscle atrophy, your focus should be treating the cause of that atrophy, which oftentimes is painful facet joints. So that's going to be an intra-articular facet injection, or the nerve going to that muscle, like the suboccipital nerve I spoke about, going to that rectus capitis posterior minor. Casey, any studies you know of or your opinion comparing platelet lysate to D5W in treating nerves? I don't think, Casey, and there's a head-to-head study. I would say that we have more good research right now on the clinical side with multiple randomized controlled trials showing that platelet-rich plasma, which is a cousin of platelet lysate, works very well for nerve repair. D5W, we've got a little bit of research on, but less. But I haven't seen a head-to-head comparison there between those two. If you were to ask me which would I trust more to help with nerve repair, it would be a platelet-based treatment. Greg, good morning. I have an upcoming PICL and SI joints in April with you. Was recently recommended to look into maybe that's an incorrect spelling, but an infectious disease due to symptoms. Could this be done or at least checked out at your clinic? No, we don't do, maybe you're talking about brucellosis or something like that, but we don't do that type of testing at my clinic. So that's something that you'll probably have to look into. I would say that that would be extraordinarily rare as a significant cause of problems in your SI joints. So I don't think it's probably worth doing, but again, I'd have to know more in the analysis. But we don't do that kind of testing looking for rare infectious diseases and whether or not they may be causing pain in the SI joints. Casey, are myofascial trigger points secondary to dysfunctional joints? How frequent is this the case? I.e., are myofascial trigger points always secondary to something else? Yeah, usually. So let's talk about that for a second. Myofascial trigger point or a trigger point in a muscle is due to an area of the muscle that's kind of bunched up and doesn't really work well, and that causes symptoms. The most common cause is actually probably the nerve going to the muscle more than anything. So myofascial trigger points can be treated via trigger point dry needling, massage, trigger point injection. You can also treat them many times by treating the nerve going to the muscle. Hi, Dr. Centeno. Hello. Can you tell when the fascia needs regen treatment? You know, you can. One of the more common things that we can see is a fascial blowout. So what's a fascial blowout? A fascial blowout would be, well, let's first talk about what a fascia is, right? You've got the muscle, and then you've got the fascial covering over the muscle. And the fascial covering is a little bit like some of those compression garments you've probably seen that some of the higher end athletes wear, right? It's compressing the muscle to allow the muscle to be more efficient. Now, fascial blowouts are when you get injury to that fascia, and as the muscle contracts, you can see it on ultrasound where you get a blowout of that fascia. So that's the easiest way to find fascial issues like that. They can be easily treated with PRP, prolotherapy, etc. Vero, how to actually see which CCI type is more closely associated with vision disturbances? That's a tough call there because they could all be associated with vision issues, Vero. Vision issues normally come from problems with the C2-3 facet joints, but also can involve C1-2 or the position sensors and proprioceptors in and around and muscle spindles in and around the suboccipital muscles. So really all of the above. Nathan, if I discover something that might need to be treated alongside ePICL, should I bring it to your attention before 3 months follow-up? Not sure what you mean there. Maybe you're talking about other parts of the body, SI joint, shoulder, etc. Probably isn't necessary to bring it up at that 3-month follow-up, but you could certainly bring it up when you're seen in the office for a subsequent PICL procedure, or maybe you want to ask, if it's multiple areas, how many areas do we think we'll be able to treat outside of just the area in around the ePICL procedure. So certainly happy to consider it at a 3-month follow-up, or just maybe give us heads up if you're going to show up and want lots of different spots treated, because we'll give you our sense of A, can we accomplish that in your particular case? And then B, is it too much? And do you need to start getting some of those things treated elsewhere? Vero, do you fit the mouthpiece once patients are asleep? Yeah, in general, what happens there, Vero, is the patient comes back. They'll get first a chlorhexidine mouthwash. Then after that, we will spray the back of the throat using kind of a numbing spray. And then patient already has an IV in. We'll start to get IV medications as we're placing the mouthpiece. So they're very, very relaxed. They may not even remember the mouthpiece itself being placed. Brett, if someone has type 2B, 3A on imaging and gets a PICL, but the actual root of their issue, chronic autonomic symptoms, are from sensitized nervous system, would the PICL actually cause more issues, or would it just be a moot point? Usually, sensitization, just so that we understand that term, sensitization in medicine means that the pain receptors are kind of on fire, and doesn't usually have to do much with the autonomic nervous system. So that may be more kind of social media discussion, or maybe a discussion through an alternative health provider. But if there's another cause for the autonomic problems, like a tumor somewhere, or some injury to the autonomic nervous system that we don't know about, then yeah, ePICL may not be all that effective, because the cause would have to be craniocervical instability. Now, having said that, we can also treat parts and pieces of the autonomic nervous system, things like the vagus nerve, for example, when we're doing an ePICL procedure. So we always try to cover that base separately, or at least almost always try to do that. Greg, have you seen some PICL candidates on social media have not been full-on surgical candidates? Is it common? Is there a reason for this? Do surgeons only look for certain criteria? Thank you. Yeah, I would say that our criteria for diagnosing craniocervical instability, Greg, are actually more strict than most surgeons. But I definitely see patients on social media that are not surgical candidates, but the vast majority of our patients are, simply because we have stricter criteria for craniocervical instability than many of the surgeons. Hey guys, if you haven't, give me a like, share, subscribe. Please do that now, because again, the way patients will find this content and the way they'll understand that on a Sunday morning they can log on and get all sorts of questions answered is if they can find content like this. And the only way they can find content like this is if you do those things. So give me a like, subscribe, etc., so that patients can find this content and that we please the algorithm so that patients who search for stuff like this have this come up. Ezra, is your in-office DMX machine up and running? It is. I remember you saying you were getting it at the beginning of the year. Also, it is better to have a DMX at your clinic versus an outside provider. Yeah, so Ezra, we definitely recommend you get the DMX done at our clinic now, simply because number one, it's a low dose setting, so we are exposing patients to far less radiation to get the images and the image sequences that we want. And number two, it's generally more convenient, right? What happens there is the person can come in a little early. They can go ahead and get that DMX right at the clinic versus having to travel to another site. And it's that second part that was the real pain in the neck, meaning when I announced that we were going to start doing DMXs at our clinic, I had a lot of patients reach out and say, well, thank you so much. It was difficult for us coming out of town, having to go and figure out where your clinic was and stay near your clinic, but then also have to go and find another clinic just to get the DMX done. So it's been really good. Mateo, anterior widening of intervertebral disc space for C6-7, evidenced by excessive segmental, I don't know what TZ is, translation maybe, possible damage to the anterior and longitudinal ligament and or intervertebral disc at that level. Can you help? So Mateo, it is possible to get damage to the anterior disc fibers or the anterior longitudinal ligament. That's the piece of duct tape that runs down the front of the spine, so that when you're in extension, you can get too much opening of the front of the disc space. Now, my practice is heavily focused on craniocervical instability and the ePICL procedure. The other doctors in my clinic, though, could easily treat that anterior longitudinal ligament or anterior disc if that's the issue. So my world, I'm only in clinic right now 2 days a week, focused only on that ePICL procedure, but the doctors in my clinic would have no problem helping you there. Natasha, can you actually see the difference in movement after the 4 months of healing on DMX? Yeah, Natasha, we do that all the time. I've probably done it twice this week. DMX or repeat DMX is an interesting phenomenon. I've got patients that are in lots of different camps. I've got patients that are in the I don't want the additional X-ray exposure camp. I've got patients who desperately want to check another DMX. And I've got patients who are in between. Their focus is on symptoms. They don't really care if their DMX is looking better or not. The other problem that we have with repeat DMX is that it doesn't correlate well, or at least it's not highly correlated to symptoms. So, for instance, I've been going back and forth all week with a patient who DMX is much better, but symptoms are still a problem. So regrettably, DMX doesn't always, or changes in DMX doesn't always correlate with improvement in symptoms. And so I would call it a okay surrogate, meaning it's good if we can see it and we know we're kind of heading the right direction. But it's not anywhere near 100% biomarker, if you will, for problems. And the reason is because in some of our patients, there's enough damage to the other structures due to the long-term instability that even if you fuse them, their symptoms wouldn't change, simply because they have those other structures that got damaged. Dr. Centeno, does the contrast used for ePICL, PICL contain gadolinium? Is IV anesthesia safer than through the mouth? Let's see. So no gadolinium. No, gadolinium is really only used for MRI contrast, not for active injection contrast through X-ray. Is IV anesthesia safer than through the mouth? I'm not quite sure what that one means. We use IV anesthesia with an ePICL procedure. I would never do an ePICL procedure by just numbing the back of the throat, simply because it's too high risk that the patient is going to move during the procedure. And if the patient moved during the procedure, that could be a really bad day for everybody. So if there's a provider offering an ePICL or a PICL or a fake and bake PICL with just local numbing because they don't have access to the use of IV anesthesia in their hospital, that would be very dangerous in my opinion. Taylor, during ePICL, what is the chance of error like poking a nerve or something that shouldn't be hit? Has anyone ever had the procedure cause irreversible damage? Taylor, let's go backwards on that one first. When it comes to irreversible damage from an ePICL procedure, we have not seen that to date, or a PICL procedure for that matter. When it comes to poking a nerve, that's always a potential issue. But again, the reason why we do what we do and use the type of imaging guidance that we do, probably the best way to conceptualize the risks of an ePICL procedure is to compare it to surgical risks, since most of our patients, or the vast majority, are surgical fusion candidates. A surgical fusion risk for something like this, for a severe injury, something that's more irreversible, requires ICU care, etc., is going to be about 1 to 2 out of 10. And that would include things like hardware coming out, or hardware needing to be redone, or lack of fusion causing a pseudoarthrosis, or sacrifice of the occipital nerve, big infection, etc. Or another one would be a dural leak. So compare that to the ePICL or PICL procedure, where for that procedure, we haven't had someone have to go to the ICU, for example. So huge difference there, 1 or 2 orders of magnitude less risk for the ePICL compared to a surgical fusion. Vero, does the standard area, or do the standard areas to inject change from PICL number 1 to number 2? It's possible, yeah. So sometimes we hold back a little bit on the number of sites with the first PICL, primarily because of a concern that the patient may not respond well to doing so much, meaning we may need to take what's called a less is more type approach. And so, yes, in some patients, we do more in number 2, for example, than we do in number 1. Now, other patients, we get the green light out of the gate. We're like, this person seems to have no evidence of sensitization or central sensitization on exam. They've had prior injections. They've had no problems with those. And there's no other contraindications, like they're actively taking THC or they're on drugs that might be a problem for recovery. So we're going to open the gate in number 1. So it really depends on the patient. E.E. Smith, will 7 Tesla MRI machines be useful for diagnosing CCI when they come out? I haven't seen a 7 Tesla. There's a few in university settings right now for research purposes, but I haven't seen a 7 Tesla in clinical use. I don't know that we're going to see them for clinical use, to be honest with you, simply because if you look at even 3 Tesla and the adoption of 3 Tesla over 1.5 Tesla, it's been super duper slow, much more slow than I would have predicted. Right now, I would say there's maybe 1 3 Tesla machine for every 10 or more 1.5 Tesla machines. So if we get 7 Tesla available commercially, my guess is it's going to be used very infrequently. Now, what might be the advantages? It would be a quicker study, because the bigger the magnet, the quicker the study. And you'll be able to get better detail. So is it possible that 7 Tesla shows us a heck of a lot more about what's going on with these ligaments than a 3 Tesla or a 1.5 can? That's certainly possible. Ezra, can you elaborate more on the low dose aspect of your DMX? Like how much less radiation? Yeah, so and how much radiation? What's the radiation comparison between DMX and a CT scan? So let's start backwards. A CT scan is by far the highest radiation dose of pretty much anything in medicine from a diagnostic standpoint. It's very, very high. A DMX is going to be much less than the average CT scan of the cervical spine, where they're taking hundreds and hundreds and hundreds of slices. And then ours is going to be about half the dose of standard DMX for two different reasons. One is that we are not taking as many X-ray pictures during the DMX. And the second is we're cutting out entire sequences like the obliques, for example, with flexion extension, that just don't add much to the diagnostic picture in our patients, or the closed mouth lateral bending. So that's how that kind of compares. CT the most, DMX next, our DMX lower than that. Let's see. JS, have you had patients who've tried biophysics chiropractic care? If so, what kind of success do they have restoring neck curvature? Yeah, so JS, a lot of our patients undergo chiropractic biophysics. You can access chiropractic biophysics by going to idealspine.com. I think it's a great technique. And it's a technique that patients should try, meaning curve restoration in general, before they consider something like an ePICL procedure. Having said that, many CCI patients just won't tolerate it well, and they tend to crash and burn with it. So oftentimes we'll have to treat them with something like an ePICL for them to be able to get there. Natalie, are outcomes any different in adolescent patients? Natalie, we generally only take skeletally mature patients. So that would mean that the adolescent has hit that growth spurt and is post-growth spurt. Now that's different for everyone, right? There's some girls that grow and are as big as they're ever going to get at age 12. And there are some boys that don't get to that point, rarely, until late teens. So, but they do have to get past that. As far as outcomes in adolescent patients, they do very well based on what I've seen, largely because they don't have the osteoarthritis burden that older patients can bring to the table, right? Sometimes we'll see a patient in their 40s or 50s or 60s that's bringing a very large neck arthritis burden to the table, in addition to craniocervical instability. So in general, they do really, really well. Undercover sentinels, 6-7 possible damage, DDD if anterior injection. Why do you say that injection is high risk? Only can be done in Colorado, or Eugenics Network can do it. What are the risks? I have much CCI symptoms. Yeah, so any disc injection is always high risk by definition. Why is it always high risk? Over the last 10 years, we've realized that the disc has a microbiome. That means that it has bacteria that live in it, and that bacteria is in a specific balance. If you do something to upset that bacterial balance, you can get what's called a discitis, or bacterial overgrowth within the disc. Usually the bacteria that overgrows is called P. acnes, kind of like acne, although it has nothing to do with acne. And if you get that, then you need 6 to 12 weeks of IV antibiotics, and you'll probably need surgery to clean out the disc itself, meaning to do a lavage and debridement. What's the risk of that in disc injections? It's as high as 1 in 300 to as low as about 1 in 1,200, depending on who you read and what precautions were taken. Was it a single needle technique, a dual needle technique? Were antibiotics used, etc.? So at the end of the day, it's not real likely that you're going to get a discitis, but it's a mess if you get a discitis. So at the end of the day, we try not to inject the disc if we can get away with it. Now, in addition, in a cervical disc injection, you're coming from the front and you've got to miss certain things that are pretty critical structures, like the internal carotid artery, the phrenic nerve that allows you to breathe, the vagus nerve that runs your entire digestive system and the brakes on the heart. And you've got to miss all of that stuff to get into the disc. So again, that adds a certain element of risk. Brett, how many PICLs have been done to date? So far, Brett, I believe we are approximately approaching 3,000, somewhere in there, over the last 11 years, with most of those being done in the last 4 to 5 years. So approximately in that range. From your own research, what do you think the long-term impact of PICL will be like for a responsive patient, like 10, 15, 20 years down the road? Yeah, Brett, the best I can answer is the 10-year mark, because we're at 11 years now. And the good news is that we don't generally see a lot of patients who have been responders coming back to get retreated unless something else happens. Now, haven't been doing this, and no one on earth has, for 20 years or even 15 years, because we're 11 right now, so I can't really answer those two. But I would be surprised if the status of that changes, but you never know. E.E. Smith, what percentage of your PICL patients have EDS? Does type 3C always indicate EDS? Maybe type 1C, because there is no type 3C. Type 3 would be A and B. But getting back to your original question, what percentage of ePICL patients have EDS? A large number of our patients have hypermobility and EDS. What percentage is that? Depends on the day, but I would say overall about 1 in 3 or more. So I'm going to say between 1 in 3 and 1 in 2 have some sort of significant hypermobility. Most of those people would carry an EDS diagnosis, whether it's presumptive. Very few these days have genetic testing, just because in the US healthcare system, getting genetic testing can be very difficult. Sarah, thank you so much for your work, and to all the doctors at CSC. PICL number 1 took me from bedbound to now spending most days out of bed. Thank you, Dr. Schultz and Dr. Rosa. I have number 2 in a few weeks. Well, Sarah, thank you so much for the shout out and the update. We always appreciate it. Listen, as I've always said, there's lots of ways to make a living, and sometimes being a doctor can be a tough way to make a living. You get called at 2 in the morning, etc. But having said that, one of the absolute wonderful things about being a doctor is hearing things like that. So thank you for throwing that out there and updating us on your recovery. Casey, do you ever use hypertonic dextrose? Yeah, so let's break that down a little bit and unpack that. So hypertonic dextrose is a prolotherapy technique. What is prolotherapy? Prolotherapy is when you inject a substance that's going to cause either local cell irritation or more accurately, small amounts of local cell death. And that's to cause a brief inflammatory healing reaction. Any hypertonic solution, meaning any solution that is more concentrated than the body's natural fluids, will cause that local cell death, and almost like a chemical debridement. Dextrose is an easy one to use. So hypertonic dextrose is a kind of a mainstay of prolotherapy injection treatment. So yes, we use hypertonic dextrose all the time when we're doing prolotherapy treatment. Joey, Dr. C, why can't pre-existing pain physician who did PRP and cervical using serum fluoroscopy, why can't they do transoral approach or posterior C0 to C2 injection? Joey, depending on their training, they could. The problem just comes in those edge cases and the danger that those edge cases present. So they just need to have a lot of additional training and they need to do a lot of those cases. So I'm going to give you a great example that demonstrates this, right? There was a medical provider in the Northeast. I had a patient, myself and Dr. Schultz, at our clinic, who was a patient from the Northeast, who had come out to Colorado for, I think, 2 injections, maybe one with me, one with Schultz, something like that. Patient did well, ultimately was feeling better and wanted a 3rd injection. And the mother was a physician, and she was asking if the patient could go see someone locally to do a 0.1 facet injection posteriorly. I said, probably not a good idea, Mom, because I don't know anyone in the Northeast who has extensive experience with this. Ultimately, she tried to get that injection in the Northeast. She was a difficult patient to position, so one of those edge cases. And the physician, who was an experienced interventional spine provider, proceeded to put the needle into her brainstem and inject. She had a brainstem stroke. And as far as I know, is still disabled from that brainstem stroke that she had because of that injection. So this is not the kind of thing that you can just pick up quickly, because screwing it up has such severe consequences for the patient. Undercover sentinel, sorry about that. Hypermobile, TOS, DDD. I get that you only do ePICL, but may at least have consultation with you. No, not at this point in my career. I've focused exclusively on CCI and ePICL. That's because I'm only in the office 2 days a week, and the demand that we have for ePICL is great enough that if I started doing other cases again, and this is only in the last year I've made this decision, we just wouldn't be able to get these patients seen. So no, I don't do that anymore. Now, we've got great docs in the clinic who do that stuff all day long and twice on Sunday. I'm not really working on Sunday, but you know what I mean. Who would be happy to see you. I've trained all of those doctors, meaning you're not allowed to work at Centeno-Schultz unless you've gone through our fellowship program. So that means that if you came out of Harvard and you didn't go through our fellowship program, we've trained Harvard docs. You can't work at Centeno-Schultz. I don't care if you come from Mass General or Yale or Cleveland Clinic or Mayo Clinic, it doesn't matter. You can't work at Centeno-Schultz until you've been through our training program, which is a year long. So I would reach out to one of the other doctors at the clinic. Success rate of fixing TOS with no predominant CC. I think I've kind of commented on this before. But the bottom line is that thoracic outlet syndrome is a common problem in patients who have neck issues. It's a very common problem in patients that have craniocervical instability. Having said that, if you get going down this vascular TOS route, you're probably going to end up with surgery, which is generally going to make the neck issues worse. How do you treat thoracic outlet syndrome? Oftentimes you treat the cervical issues that are causing it and or associated shoulder issues like AC joint instability. Sometimes you can hydrodissect the scalene areas or the inner scalene area in order to open up that space as well. JS, have you had patients who have used alpha lipoic acid to heal nerve damage? I don't, well, listen, I'm sure we have. Having said that, I don't recall anyone who has used that and come back to me and said, hey, my nerve damage is dramatically better, or my nerve symptoms are dramatically better. It's certainly good to use supportive supplements like omega-3s and alpha lipoic acid and B vitamins and other things for nerves. But do I think that that's going to completely take care of the problem in most of our patients? It's not. Greg, hello, not infectious structural Bertolotti syndrome is still largely unrecognized congenital abnormality that causes pain in lower back and legs. Yeah, I think here you're talking about a congenital fusion of L5 to the sacrum. Again, we see that all the time. In general, doesn't cause symptoms. Now, what can it do? It can overload the 4-5 area, and it can overload the SI joints. So there's no magic to treating something like that. You would just treat the adjacent segments, usually the L4-5 segment and or the SI joint segments. DZZ, I've submitted my information to your call center last week, still waiting for the first consultation. Yeah, so just so that you know, DZZ, what we do is if you're coming in for CCI-related care, there's a pre-screen. Now, I pre-screen the patients, and my pre-screen really looks at the imaging side. And do we have enough imaging to make a determination as to whether or not this person has CCI? If we do, then do they have a type of CCI that might need an ePICL procedure, or posterior injection is going to help, so that I can route the person to the right direction? Or if we don't have the right imaging, then we can get that imaging. Because one of the things I hate, because it's bad for the patient, is when they spend money on a telemedicine and we do the telemedicine, and the real conclusion of the telemedicine is we don't have enough information to make a diagnosis. So that's why I pre-screen those, to try to make sure we don't get to that point. J-Men, the amount of stem cells you use, would it be more if not for FDA regulations? I always see more being used outside of the USA, much higher amounts. That's really going to, so we have a Cayman clinic where we culture expand cells. We've been doing that longer than anyone on the face of the earth for clinical use, for sure. There's no one even who's a close second. And we don't use it for a lot of things, right? There's no need to culture expand cells if you're treating a ligament, for example. There's no need to culture expand cells if you're treating certain kinds of conditions. Now, there's some advantages for culture expanding cells if you need to treat lots of different areas, or if you need to treat specific areas that might be otherwise hard to treat. So if we could do culture expansion in the United States, would it change things? Certainly be nice. Wouldn't have to take patients down to Grand Cayman, for example. Having said that, we'd still probably treat 85, 90% of the patients in the same way we currently do. Tommy, would this method be effective with maybe a retroflexed odontoid, basilar invagination, platysma, ectopy of the cerebral tonsils of 7 millimeters, with CXA of 115, some high static images? You know, Tommy, I don't do online bedside consults. It's not fair to the patient, certainly not fair to me either. I can say that we treat lots of patients with retroflexed odontoids. That doesn't seem to be a determining factor as to whether or not they get better or not. As far as basilar invagination goes, I need to know more about that diagnosis, because I see that diagnosis being made many times when it's not present, i.e. when there's maybe a violation of Chamberlain's line, but there is no actual MRI evidence of basilar invagination. And then with a Carry 1 plus, again, I'd have to see the context. So I can't really answer that in the way it's been asked in this scenario. Nathan, is a honeymoon period a good indicator to continue ePICL treatment? Yeah, I think it's a great indicator because it tells us that if you're getting that stability from inflammation of the ligaments, that helps that person. Sarah, would patients be able to do a follow-up DMX at the clinic for a PICL procedure, i.e. before number 3? Yeah, Sarah, that's not a problem. We can certainly go ahead and have you do that. That's really up to the patient and, in consultation with their doctor, right? Okay, so guys, I think we are past the time, and as usual, I got more questions than I can answer. So I'm probably going to wrap this up here at this point. I want to thank everyone for great questions. As I always say, there are no bad questions. Good questions that are all over the place allow other patients to learn. And I want to thank everyone for taking the time this Sunday morning with me. This next Sunday, I don't think I'll be here. I'll have to figure out how we're going to do that one, just because I've got a wedding I have to go to. But we'll play that one by ear. We'll see if I do it on the Thursday or just can't get it done because there's too much going on. So have a great week and keep all the great questions coming. Thanks so much.